Let's see about glaucoma. First, see about treatment physiology of glaucoma. Applied anatomy. Pathophysiology of glaucoma revolves around aqueous humor dynamics. It's mainly based on aqueous humor dynamics. The principal ocular structures concerned with the ciliary body, angle of anterior chamber, and aqueous outflow system. Ciliary body, it is the site of aqueous production. It is the site of aqueous production. Angle of anterior chamber. Angle of anterior chamber plays an important role in the process of aqueous drainage. It is formed by root of iris, anterior most part of ciliary body, scleral spur, trabecular measure, and Schwalbe's line. And the angle width varies in different individuals and plays a vital role in pathomechanism of different types of glaucoma. Let's see about gonioscopic grading of angle width. Before that, let's mark the angle formation. It is found by root of iris, anterior most part of ciliary body, scleral spur, trabecular measure, and Schwalbe's line. This is iris, and this is cornea, and anterior chamber angle. This is anterior chamber angle. Trabeculum and Schlimm's canal. It is a drainage. Okay. Gonioscopic grading of angle width. Various systems have been suggested to grade angle width, and the most common used are Schafer's system of grading angle is given in table 10.1. Let's see in future further. Aqueous outflow system, it includes trabecular measure, Schlimm's canal, and collector channels, aqueous veins, and episcleral veins. We'll see in figure 10.3. And the first one is trabecular measure. It is a sieve-like structure through which aqueous humor leaves the eye. It consists of 3 layers which from inside out are uveal measure, corneoscleral measure, and juxtacanalicular measure. Uveal measure, it is the innermost part of trabecular measure and extends from iris, root, and ciliary body to Schwalbe's line. The arrangement of uveal trabecular bands are creating an openings of about 25 micron to 75 micron in width and diameter. Corneoscleral measure, it forms the large middle portion which extends from the scleral spur to lateral wall of scleral sulcus. Scleral spur to lateral wall of scleral sulcus. It consists of sheets of trabecula that are perforated by elliptical openings which are smaller than those in uveal measure. Juxtacanalicular measure, it forms the outermost portion of trabecular measure and consists of juxtacanalicular space and cells. The juxtacanalicular cell cytoplasmic process attached externally to process arising from inner wall endothelium of Schlimm's canal, and internally to processes arising from the cells of corneoscleral measure. Thus, this narrow part of trabeculum connects the corneoscleral measure with Schlimm's canal. This part of trabeculum measure mainly offers normal distance to aqueous outflow. The second part in the aqueous outflow system is Schlimm's canal. Before that, we will see the given diagrams. Schafer's system of grading angle width. Grade 4, grade 3, grade 2, grade 1, S and 0. Here let's see the diagram. Grade 0, we will not see any of the structure. Grade 1, we will see simply the TM. Grade 1, we will see SL only. SL is Schwalbe's line. This one is Schwalbe's line. We will see only Schwalbe line. And grade 2, we will see trabecular measure and Spalby line. Grade 3 we will see both scleral spur, trabecular measure and Spalby line, and grade 4 we will see all of the 4 structures: ciliary body band, scleral spur, and the trabecular measure and the Spalby line. The aqueous outflow system, it's ciliary efferent vein, and from here the aqueous humor arises and flows through the iris, and then it comes out through the trabecular measure. This is the Schlemm's canal. Here it drains through the aqueous vein and interscleral plexus, episcleral vein, and anterior ciliary vein, etc. This is sclera. So this is the aqueous outflow system. Let's move on to Schlemm's canal. This is an endothelial lined oval channel present circumferentially in the scleral sulcus. The endothelial cells of its inner wall are irregular, spindle shaped, and contain giant vacuoles and are aqueous wall. The outer wall of the canal is lined by smooth flat cells and contains the opening of collector channels. These are also called intrascleral aqueous vessels, are about 25 to 35 in number and leave Schlemm's canal at oblique angles to terminate in episcleral veins in a laminated fashion. These intrascleral aqueous vessels can be divided into two systems: direct system and indirect system. Direct system is formed by large vessels, aqueous veins, and indirect system is formed by small collector channels which form intrascleral plexus before eventually going into episcleral veins. Let's see the applied physiological process concerned with dynamics of aqueous humor or its protection, drainage and maintenance of intraocular pressure. Aqueous humor and its protection. Volume. The aqueous humor is a clear watery fluid filling the anterior chamber and posterior chamber of the eyeball. Functions of aqueous humor: maintenance of a proper intraocular pressure, metabolic and nutritional, gives nutrient substrates, nutrition, and oxygen to lens and cornea. Optical function: it maintains optical transparency. Clearing function: aqueous humor serves as consider clear blood, macrophage, remnants of lens matter. Production of inflammation from anterior chamber. Products of inflammation from the anterior chamber. Thus, it takes the place of lymph, and it substitutes the lymph and which is absent in the eyeball. It's absent in the anterior and posterior chamber. Refractive index: aqueous humor has a refractive index of 1.336. Composition of aqueous humor includes water 99% and solids 0.1%, which include mainly proteins. Colloid content: because of blood aqueous barrier, the protein content of aqueous is much less than that of plasma. Protein is less, but it is present. However, in inflammation of uvea, the blood aqueous barrier is broken and protein content of aqueous is increased due to mixing of blood. Amino acid constituent of aqueous humor is about 5 mg per kg of water. Non-polar constituent millimoles per kg water are glucose, urea, ascorbate, lactic acid, inositol, and Na plus 144, K plus 4.5, Cl chloride 10, and CO3 bicarbonate 34. Oxygen is present in aqueous humor in dissolved state. Thus, composition of oxygen is similar to plasma except that it has high concentrations of bicarbonate, ascorbic acid, pyruvate, and lactate, low concentrations of protein, urea, and glucose. Low concentrate, high concentrate. Okay. Aqueous humor, anterior chamber versus posterior chamber. The composition of aqueous humor in anterior chamber differs from that of aqueous humor in posterior chamber because of metabolic interchange. The main difference are bicarbonate in posterior chamber, aqueous is higher than in anterior chamber. Chloride concentration in posterior chamber is lower than in anterior chamber. Ascorbic concentration of posterior aqueous is slightly higher than that of anterior aqueous. In anterior chamber, chloride content is high, and in posterior chamber, bicarbonate content is high. Aqueous humor formation. Aqueous humor derived from plasma within the capillary network of ciliary process. The normal aqueous production rate is 2.3 microliter per minute. The three mechanisms are diffusion, ultrafiltration, and secretion. play a part in its production at different levels. The steps involved in process of production are summarized below. Ultrafiltration, secretion, and diffusion. First, let's see about ultrafiltration. First of all, by ultrafiltration, most of the plasma substance pass out from the capillary wall and lose connective tissue. Thus, plasma filtrate accumulates behind the pigmented non-pigmented epithelium of ciliary process. Secretion. First, diarysate, which is the plasma filtrate. From the plasma is transferred into pigmented epithelium. Paired Na plus and H plus and Cl minus HCO3 antipodes actively transfers Na plus and Cl minus from stroma into cells. Intracellular gap junction also play a critical role. A tight junction between cells of non-pigmented epithelium create part of a blood aqueous barrier. Certain substances are actively transported across this barrier into posterior chamber. The active transport is brought about by Na plus K plus activator, ATPase pump, calcium and voltage gated ion channels, and carbonic and nitric enzyme system. Substances that are actually transported include sodium chloride, potassium, ascorbic acid, amino acid, and bicarbonates. Diffusion. Active transport of these substances across non-pigmented ciliary epithelium results in osmotic gradient, leading to movement of other plasma constituents in posterior chamber by ultrafiltration and diffusion. Sodium is primary response for movement of water into posterior chamber. As the aqueous humor passes from posterior chamber to Schlemm's canal, there occurs sufficient diffusion exchange with the surrounding substance. As a result, the anterior chamber aqueous submerges plasma more closely than thus the posterior chamber aqueous humor. Control of aqueous formation. The diurnal variation in intraocular pressure certainly indicates that some endogenous factors to influence the aqueous formation. The exert role of such factors is to be clearly understood. Vasopressin and adenine cycles have been described to affect the aqueous formation by influencing the active transport of sodium. Ultrafiltration and diffusion, which primarily operate against concentration gradient. The passive mechanism of aqueous formation are dependent on level of blood pressure in ciliary capillaries, the plasma osmotic pressure, and the level of intraocular pressure. Drainage of aqueous humor. The aqueous humor flows from the posterior chamber into anterior chamber through pupil against slight physiological resistance. From the anterior chamber, the aqueous is drained out by two routes, trabecular vessel and through Schlemm's canal. Trabecular vessel is the main outlet for aqueous humor. Approximately 70 to 80% of total aqueous is drained. Free flow of aqueous occurs from trabecular vessel up to inner wall of Schlemm's canal, which appears to provide some resistance to outflow. Mechanism of aqueous transfer across inner wall of Schlemm's canal. Passive filter methods. Earlier it was believed that from juxtacanalic space the aqueous humor enters the Schlemm's canal against slight resistance. Following mechanisms were postulated, which are now discarded and have become a part of historical interest only. Leaky pores in endothelial cells forming the inner wall of Schlemm's canal were proposed. Contractile microfilaments in the endothelial cells were suggested by some of the Sondermann's canal were also suggested. Vacuolation theory, it was one of the most accepted due to reason. According to it, transcellular spaces exist and in endothelial cells forming inner walls of Schlemm's canal. These open as a system of vacuoles and pores primarily in response to pressure and transport the aqueous from juxtacanalicular connective tissue to Schlemm's canal. See the diagram 10.4. Aqueous outflow active pump mechanism. Aqueous flow through aqueous outflow system has long been considered a passive filter mechanism against to pressure gradient. However, recently it has been reported that aqueous outflow system acts as biomechanical pump. It has been proposed that aqueous outflow pump operates through oscillatory pressure transients caused by ocular pulse, blinking and eye movements. Trabecular measure actively moves outward and recoils back in response to oscillatory pressure transients. Thus, trabecular measure flexibility is essential for aqueous outflow pump mechanism. aqueous valve mechanism. It has been got to operate at level of inner wall of Schlemm's canal. These valves are oriented circumferentially in Schlemm's canal and the lumen is continuous with the juxtacanalicular space. These valves allow one-way passage of aqueous humor from the juxtacanalicular space to inside of the Schlemm's canal and not vice versa. Aqueous flow pump is a part of vascular circulatory loop. During cardiac diastole, the IOP is slightly decreased due to less blood flow to choroidal vasculature. As a consequence, the trabecular muscle is retracted inward, leading to negative pressure inside Schlemm's canal and opening of the aqueous valve. This is followed by flow of aqueous inside the Schlemm's canal. Aqueous humor flow from Schlemm's canal to collector channel and X-ray ravines. During cardiac systole, the choroidal vascular expansion leads to transient rise in intraocular pressure. The aqueous pulse wave distances the trabecular muscle, forcing it outwards against the Schlemm's canal. As a consequence of this pressure push, the aqueous valves close and the aqueous from the Schlemm's canal is pushed through the collector channel in its outer wall into aqueous veins. From the aqueous vein, aqueous is pushed into the muscular vein by the same mechanism. The pressure gradient between IOP 16 and muscular vein pressure about 10 mm also facilitates the unidirectional pulsatile flow of aqueous humor. The second outflow is EVA scleral outflow. It is responsible for about 20 to 30% of total aqueous flow, and the aqueous enters the ciliary body through the iris root and ciliary body face and uveal trabecular muscle. Aqueous passes across ciliary body between bundles of ciliary muscle into suprachoroidal space and is drained by venous circulation of ciliary body, choroid and sclera. Maintenance of IOP. IOP is maintenance. IOP is 10 to 21 of Hg. Normal IOP. The normal level is maintained by dynamic equilibrium between formation of aqueous humor. The factors associated with the local factors, rate of aqueous formation, resistance to aqueous flow, increased episcleral venous pressure may result in rise of IOP. We'll see we'll come back to that point. Vacuolation theory of aqueous transfer across the inner wall of Schlemm's canal. Non-vacuolated stage. 1 is non-vacuolar stage. 2 is stage of early infolding of basal surface. 3 is stage of macrovascular structure formation. 4 is stage of vacuolar transcellular channel formation. And 5 is stage of occlusion of basal infolding. Flow of fluid chart depicting drainage of aqueous humor. Ciliary process. Aqueous in posterior chamber, through people anterior chamber, trabecular muscle, ciliary body, Schlemm's canal, suprachoroidal space, collector channel, trabecular conventional flow, venous circulation of ciliary body and choroid and sclera, EVA scleral, unconventional 20 to 30% flow. Dilation of pupil in patient with narrow anterior chamber angle may cause rise of IOP. Owing to a relative obstruction of aqueous drainage by iris. Refractive errors. Myopic individuals have higher IOP as compared to emmetropes and hypermetropes. In fact, IOP correlates with axial length. General factors: hereditary, age, sex, diurnal variation, postal variation, seasonal variation, blood pressure, osmotic pressure of blood, general anesthetic, etc. Exercise. Strenuous exercise lowers IOP. Blood pressure as such, it does not have long-term effect on IOP. Our prevalence of glaucoma is marginal in hypertensives. Postal variation, IOP increase when changing from sitting to supine position. Diurnal variation, usually there is higher IOP in morning and lower in evening. Age above 40 years and the IOP increase, mean IOP increase. Glaucoma and overview. Definition: glaucoma is not a single disease caused by a group of disorder. Neuropathy resulting in characteristic appearance of optic disc and specific pattern of irreversible visual field defects, and are associated frequently but not variably with increased intraocular pressure. EOP is most common risk factor but not only risk factor for development of glaucoma. Consequently, the term ocular hypertension is used for his having constantly raised IOP without any glaucomatous change. Conversely, the term normal or low tension glaucoma is suggested for typical cupping of disc and visual field defects associated with low IOP. Classification: clinical etiologic glaucoma may be classified by A. Congenital development glaucoma, primary congenital glaucoma, developmental glaucoma, and primary adult glaucoma, primary open glaucoma, primary angle closed glaucoma, primary mixed mechanism glaucoma, and secondary glaucoma. Epidemiology and pathogenesis of glaucomatous ocular change. As mentioned in definition, all glaucoma are characterized by a progressive optic neuropathy. It has now been recognized that progressive optic neuropathy results from death of retinal ganglion cells. Pathogenesis of retinal ganglion cell death. Retinal ganglion cell death is initiated when some pathological event block the transport of growth factors from the brain. The blockage of neurotropins initiated damaging cascade, and cell is unable to maintain its normal function. The RGCs losing their ability to maintain normal function undergoes apoptosis and also trigger apoptosis of adjacent cells. Apoptosis is a genetically controlled cell suicide program whereby irreversibly damaged cells die and are subsequently engulfed by neighboring cells without eliciting any inflammatory response. It is also associated with loss of retinal nerve fibers, and as the loss of nerve fibers extend beyond normal physiological overlap function, the characteristic optic disc changes occurs. Etiological factors: raised intraocular pressure, mechanical theory. It causes a mechanical stretch on lamina cribrosa, leading to axonal deformation and ischemia by altering capillary blood flow. As a result, neurotropins are unable to reach the retinal ganglion cell bodies. Pressure independent factors: vascular insufficiency theory. Factors affecting vascular perfusion of optic nerve head in absence of raised IOP have been implicated in glaucomatous optic neuropathy in patients with normal tension glaucoma. However, these may be additional factors in case of raised IOP as well. These factors include failure of autoregulatory mechanism of blood flow. Vasospasm is another mechanism affecting vascular perfusion of optic nerve head. And systemic hypotension, particularly nocturnal dips in patients with nighttime administration of antihypertensive drugs have been implicated for low vascular perfusion of optic nerve head and progression of damaging POAG. Other factors such as acute blood loss and abnormal coagulation field have also been associated with NTG. Congenital and developmental secondary insults, excitotoxicity theory. Neuron degeneration believed to be driven by toxic factors such as glutamate, excitatory toxin, oxygen-free radicals, or nitric oxide, which are released when RGCs undergo death due to primary insults. In this way, the secondary insult leads to continued damage mediated apoptosis. Congenital development glaucoma. The types are primary developmental congenital glaucoma, developmental glaucoma with associated systemic anomalies, developmental glaucoma with associated congenital ocular anomalies, primary developmental congenital glaucoma. Primary congenital developmental glaucoma. It refers to abnormally high IOP which results due to developmental anomaly of angle of anterior chamber, not associated with any other ocular or systemic anomaly. Depending upon the age of onset, the developmental glaucoma termed as follows: Newborn glaucoma, also called as true congenital glaucoma, is labeled with IOP, is raised during intrauterine life and child is born with ocular enlargement. It accounts for about 40% of cases. Infantile glaucoma is labeled when the disease manifests prior to child's third birthday. It accounts for about 50% of cases. Juvenile glaucoma, it's labeled rest 5% of cases who develop pressure rise after 3 years of age. Also known as juvenile primary angle open glaucoma, about 35% with juvenile POAG or myopes. The disease has a strong autosomal dominance inheritance. Some of the families suffering from juvenile POAG have a genetic anomaly and long arm of chromosome 21 ophthalmus. When the disease manifests prior to age 3, the eyeball enlarges, so the term ophthalmus, bull-like eyes. As it results due to retention of aqueous humor, the term hydrophthalmus has also been suggested. Prevalence and genetic pattern. Sporadic occurrence is seen in most cases. Autosomal recessive inheritance with incomplete penetrance is seen in about 10% cases. Loci linked with PCG are TP2P21 and 1P36 and 14Q24. Sex linkage is not common in inheritance, although over 60% of patients are boys. Bilateral occurrence is seen in 70% cases. Prevalence of disease only one child in 10,000 birth. Pathogenesis, mall development from neural plus derived cells of trabeculum, including iridotrabecular junction, is responsible for impaired aqueous outflow, resulting in raised IOP. In primary congenital glaucoma, trabeculodysgenesis is not associated with any other major ocular anomalies. Clinically, trabeculodysgenesis is characterized by absence of angled recess with iris having a flat or concave direct insertion into surface of trabeculum as follows. Flat iris insertion is more common than concave iris insertion. In it, the iris inserts flatly and abruptly into thickened trabeculum either at or anterior to scleral spur or posterior to scleral spur. It is often possible to visualize a portion of ciliary body and scleral spur. Concave iris insertion is less common. In it, the superficial iris tissue sweeps over the iridotrabecular junction and the trabeculum and thus obscure the scleral spur and ciliary body. There are two types of iris insertion: flat iris insertion and concave iris insertion. Clinical feature: lacrimation, photophobia, blepharospasm, etc. These are often together and form classical triad of congenital glaucoma: lacrimation, photophobia, and blepharospasm. Often there is history of rubbing of eyes. It is caused by irritation of corneal nerves which occur as a result of elevated IOP. Photophobia is initial sign. Corneal signs include edema, enlargement, and deciment breakage. Corneal edema is frequent the first sign, which arouses suspicion. At first it's epithelial, but later there is stromal involvement and permanent opacity may occur. Corneal enlargement, it occurs along with enlargement of lobe ophthalmus, especially when onset is before age of 3 years. Tears and break in deciment membrane and diameter of more than 13 mm confirms enlargement of cornea. Prognosis poor before 16 mm diameter of cornea. Tear and break in deciment membrane, these occur because deciment membrane is less elastic and the corneal stroma than the corneal. Tears are usually peripheral, concentric with limbus and appear as lines with double contour. Sclera becomes thin and its becomes deep. Iris may show iridodonesis, atrophy patches in later stages. Lens become flat due to stretching of junctions and may even subluxate backward. Optic disc may show variable cupping and atrophy, especially after third year. IOP is raised, which is neither marked nor acute. Axial myopia may occur because of increase in axial length, which may give rise to anisometric amblyopia. Examination: measurement of IOP by shots or preferably handheld Perkin approximation tonometry, since clear rigidity is very low in general. IOP measurement by under GA is unpredictably altered. Corneal enlargement. Measurement of corneal diameter by calipers. Slit lamp examination should be carried out with portable slit lamp. Ophthalmoscopy to evaluate optic disc, and gonioscopic examination of angle of antichamber reveals trabecular distance with either flat or concave iris insertion, as described in pathogenesis. Then differential DD, differential diagnosis. Cloudy cornea. In unilateral cases, the commonest cause is trauma with the rupture of decimal membrane. In bilateral cases, causes may be trauma, mucopolysaccharidosis, interstitial keratitis, and corneal endothelium dystrophy. Large cornea due to buphtalmus should be differentiated from megalocornea, sclerocornea, and high myopia. Lacrimation is an infant. In an infant is usually considered due to congenital nasolacrimal duct blockage, and thus early diagnosis of congenital glaucoma may be missed. Photophobia may be due to keratitis or uveitis. Other cases of watering are corneal aberration, Niesmann's clearing, corneal dystrophy, raised buccal dystrophy. Raised IOP in infants may also be associated with retinoblastoma, retinopathy of prematurity, traumatic glaucoma, secondary congenital glaucoma, primary hyperplastic vitreous, etc. Optic disc change need to be differentiated from congenital anomalies of disc such as pit, coloboma, hypoplasia, tilted disc, and large physiological cup. Treatment, medical treatment. Medications are not very effective, so treatment of congenital is primary surgical. However, IOP must be lowered by medical treatment with hyperosmotic agents, acetazolamide, beta blockers. Still surgery is taken up. Miotics are not used in such cases because a paradoxically increased IOP. Alpha 2 agonist brimonidine causes CNS depression in children and is contraindicated. Surgical procedure for congenital cataract. Incisional angle surgery, goniotomy. In this procedure, bark and goniotomy knife is passed through limbus temporal side. Under gonioscopic control, the knife is passed across anterior chamber to nasal part of angle, and incision made in angle approximately midway between root of iris and Schwalbe's ring through approximately 75 degree. The knife is then withdrawn. Although procedure may have to be repeated, eventual success rate is about 85%. Trabeculotomy. This is useful when corneal clouding prevents visualization of angle or in cases where goniotomy has failed. In this, canal of sclems is exposed at about 12 o'clock position by vertical scleral incision after making congenital flap and partial thickness scleral flap. The lower prong of Holmes trabeculotomy is passed through sclems canal on one side, and upper prong is used as guide. Then the trabeculotomy is rotated so as to break the inner wall over 1/4 of canal. This is then repeated on the other side. The main difficulty in this operation is localization of sclems canal. Filtration surgery is required in many cases. Trabeculotomy with antimetabolics give good results. Combined trabeculotomy and trabeculotomy with antimetabolics has been accepted as standard procedure. Glaucoma drainage devices are required in incalcitrant cases. Technique of goniotomy, line of sight. So A showing position of goniotomy knife in the angle under direct visualization. B showing process of sweeping the knife in the right angle. Okay. Techniques of trabeculotomy. Development of glaucoma with associated ocular anomalies. Glaucoma with aniridia, glaucoma with family iris hypoplasia, glaucoma with congenital ectropia and glaucoma with congenital microcornea, and glaucoma with congenital non-ophthalmos. These are associated with other ocular anomalies. Glaucoma with iridocorneal distances, posterior embryotoxon, Axenfeld-Rieger syndrome, Axenfeld anomaly, Rieger anomaly, Rieger syndrome. Peters anomaly is characterized by central corneal opacity. It may have other ocular some systemic association as well. Combined Rieger syndrome, Peter anomaly, development glaucoma with systemic anomalies, glaucoma with chromosomal disorder, 13 trisomy, 13 to 15 trisomy, 18 trisomy, 21 trisomy Downs, Turner syndrome, glaucoma with ectopia lentis syndrome, which include Marfan, Weil, Merchisani, homocystinuria. Glaucoma with phacomatosis is seen in Sturge-Weber syndrome, 50% cases, von Recklinghausen's neurofibromatosis, 25% cases, glaucoma with metabolic syndrome such as Lowy syndrome, oculocerebrorenal syndrome, Hurler syndrome, mucopolysaccharidosis, Zellweger syndrome. Then let's see about primary open angle glaucoma and associated conditions. Primary open glaucoma, it is primary glaucoma where no obvious systemic or ocular cause of rise in intraocular pressure is seen. Primary open glaucoma is open glaucoma is characterized with slow progressive rise in intraocular pressure. Open normal appearing anterior chamber, characteristic optic disc cupping, and specific visual field effects. It is slowly progressive rise in intraocular pressure greater than 20 mm, occurred at least few occasions. Predisposing factors, intraocular pressure is the most important factor. Family history, family history also seen in 10% sibling and 4% offspring of patient with parents with glaucoma. EOG has a polygenic inheritance. Approximately 2 dozen loci have been identified. Only following 3 genes have been codoned: myosin C, optineurin, WD repeated domain, WDR36. Age increase with age, elders between 5th to 7th decades. Race common in black people than whites. Myopes are more common. Central cornea thickness thinner CCT. Apart from causing underestimation of IOP by aplanation tonometer, is considered as an independent risk factor of EOAG. Diabetes as a high prevalence, cigarette smoking also increase risk. High blood pressure is not the cause of rise in IOP. However, the prevalence of EOG more in hypertension than normal tensives. Diastolic perfusion pressure is related to glaucoma. Diastolic perfusion pressure of less than 50 mm Hg is an important risk factor for glaucoma. Thyroidosis, it is also not the cause of rise in IOP, but prevalence of EOG is more in thyroidosis condition. Corticosteroid responsiveness, other things have raised in IOP. The first is thickening and sclerosis of trabecular measure and faulty collagen tissue. Second is narrowing of intratrabecular spaces, deposition of amorphous material in juxtacanalicular space, collapse of Skyne's canal and absence of giant vacuoles in the cells lining it. Exact cause of these changes is uncertain. Detection of increased gamma globulin and plasma cells in trabecular measure on immunohistochemistry in positive antinuclear antibody reaction in some cases support an immunogenic mechanism in BOAG. Epidemiology of BOAG. Then clinical features, symptoms. There are 6 symptoms. Asymptomatic, mostly inside is nonsense, and headache and ache of mild intensity may occur. Scotoma is most common symptoms. It may be noticed by some observant patients. Difficulty in reading and close work, often persistently increasing, is experienced by most patients. This occurs due to increased cognitive failure as a result of constant pressure on ceiling muscle and its nerve supply. Delayed doubt adaptation may develop disability, which become increasing disturbing in the later stages. Significant loss of vision and blindness is the end result of untreated cases. Signs: anterior segment signs. It is done using ocular experiment done using slit lamp biomicroscope may reveal normal anterior summary. In late season, pupil reflex becomes sluggish, and cornea may show slight haze. Low central corneal thickness is a significant risk factor. Intraocular pressure changes. In the initial stage, IOP may not rise permanently, but there is exaggeration of normal diurnal variation. Therefore, repeated observation of IOP every 3 to 4 hours for 24 hours is required during this stage. Morning rise. Different patterns of diurnal variation of IOP is shown. Or morning rise in 20% cases, afternoon rise 25%, biphasic both morning and evening rise in 50% of cases. A variation IOP of over 5 mm Hg shorts is suspicious, and over 8 mm which is diagnostic of glaucoma. In later stages, IOP is permanently raised about 20 mm Hg and ranges between 30 to 45 mm Hg. Optic disc changes usually observed on routine fundus examination provide an important clue for suspecting POAG. These are typically progressive and asymmetric and presents a variety of characteristic clinical pattern. It is essential, therefore, to record the appearance of nerve head in such a way that will accurately reveal subtle glaucomatous changes over the course of follow-up evaluation. Examination technique: careful fundus examination should be performed to detect optic disc changes. Best technique is to have stereoscopic view of optic disc with contact or non-contact lens on slit lamp biomicroscope examination. Non-contact lenses are more convenient and are thus widely used. The power of non-contact lens uses 78D or 90D. Recording and documentation techniques include serial hand drawings, photography, photogrammetry, confocal scanning, laser topography, that is Heidelberg retinal tomograph is an accurate and sensitive method of its purpose. Other advanced imaging techniques include optical coherence tomography, scanning, laser polarimetry, that is nerve fiber analyzer. Glaucomatous change in optic disc can be described as early changes, advanced changes, and glaucomatous optic atrophy. Early glaucomatous changes are vertical overcome due to selective loss of neural rim tissue in the inferior and superior poles. Asymmetry of the difference of more than 0.2 between two eyes is significant. Large cup 0.6 or more. Normal cup size is 0.3 to 0.4 may occur due to concentric expansion. Splinter hemorrhages present on or near optic disc margin. Palar regions on disc. Patterns of diurnal variations. A is normal straight morning rise. B is morning rise seen in 20% of cases of POAG. C is afternoon rise seen in 25% of POAG. D is biphasic variation. Let's see the optic disc changes. Normal optic disc. A, hygromatic depiction. B, fundus photography. B is optic disc showing early glaucomatous changes. Atrophy of retinal. This is anterior. This is early glaucomatous changes. Early glaucomatous changes. Sixth is atrophy of retinal nerve fiber layer, which may be seen with red-free light. Advanced glaucomatous changes in optics include marked cupping, 0.7 to 0.9 mm excavation may even reach the disc margin, and the sides are steep and not shelving. Deep physiological cup, which are well delineated on OCT examination. See the diagram in next image. Then thinning of neuroretinal rim. Thinning of neuroretinal rim, which occurs in advanced cases, is seen as crescenting shadow adjacent to disc margin. Normally, the thickest to thinnest part of neuroretinal rim of optic disc are inferior, superior, nasal, and temporal. ISNT rule. Any variation from this helps to detect glaucoma. Notching of rim, especially up to disc margin, is pathognomic. Nasal shifting of retinal vessels, nasalization, which have the appearance of being broken off at the margin, is important sign. It is bio-netting sign. It is nasalization of the retinal vessels. Bio-netting. When the edges overhang, the course of vessels as they climb the sides of cup is hidden. Pulsation of retinal arteries may be seen at the disc margin when IOP is very high. Lamellar dot sign in the pores of lamina purpurosa are slit-shaped and are visible up to the margin of the disc. Glaucomatous optic atrophy. As the damage progresses, all the neural tissue of disc is destroyed and the optic nerve head appears white and deeply excavated. See the diagram. For the pathology of disc changes, both mechanical and vascular factors play an important role in cupping of disc. Mechanical effect: rise of IOP forces the lamina purpurosa the lamina purpurosa backwards and squeezes the nerve fibers within its meshes to destroy axonoplasmic flow. Vascular factors contribute in ischemic atrophy of the nerve bases without corresponding increase of supporting glial tissue. As a result, large caverns of lacunae are formed, cavernous optic atrophy. Visual field defects. It appear only after about 40% of axons have been damaged, and subsequently the field defects usually run parallel to the changes at optic nerve head and continue to progress if IOP is not controlled. These can be described as early and late field defect. Anatomical basis of field defects. For better understanding of the actual failure, it is mandatory to have knowledge of their anatomical basis. Let's see the images. Optic disc showing advanced glaucomatous changes. A is diagrammatic depiction. B is fundus photography. C is OCT picture. D and E depiction of fundus optic diagrammatic depiction fundus photography glaucomatous optic atrophy. Anatomy of visual field defects. A is distribution of retinal fiber. Fibers from the nasal half of retina come directly to optic disc as superior and inferior radiating fibers. Those from the macular area come horizontally as papillomacular bundle. Fibers from temporal retina arched upon below macula, and papillomacular bundle as superior and inferior arcuate fiber with a horizontal raphe in between. Arrangement of nerve fibers. These from peripheral part of retina lie deep in the retina but occupy the most peripheral superficial part of optic disc, while fibers originating closer to nerve bed lie superficially in the retina and occupy a more central portion of the disc. The arcuate nerve fibers occupy the superior and inferior temporal portion of optic nerve and are most sensitive to glaucomatous changes, accounting for early loss in corresponding regions of vision. Macula fibers are most resistant to glaucomatous damage and explain the retention of central vision till end. Macular fibers and arcuate fibers. Papillomacular bundle. These are arcuate, superior arcuate fibers and superior inferior arcuate fibers and these are superior and inferior ADT fiber. This is macular fibers. The first one to affect are arcuate fiber, but macular bundle remains. It provides resistance to glaucomatous changes. Normalization of glaucoma field defects, most are scotomas, and visual field defects in glaucoma are initially observed in Jerum's area, 20 to 25 degree from fixation. And correlated with optic distance, the natural history of progressive glaucomatous field loss and more or less takes the following sequence: isopter contraction. It refers to mild generalized constriction of central as well as peripheral field. It is earliest visual field defect occurring in the glaucoma, earliest. However, it is of limited diagnostic value and as it may also occur in many other conditions. Bearing of blind spot. It also considered to be an early glaucomatous change. It is but it is very non-specific and thus of limited diagnostic value. Bearing of blind spots means exclusion of blind spot from central field due to inward curve of outer boundary of 30 degree central field. Small wing shaped paracentral scotoma. It is earliest clinical significant field. It may appear either below or above the blind spot in Jerum's area. An arcuate area extending above and below blind spot between 10 to 20 degree in fixation point. Cedal scotoma with passage of time. Paracentral scotoma joins the blind spot to form a sickle shaped scotoma known as cedal scotoma. Arcuate or it is formed at a later stage by Jerum's scotoma. Extension of cedal scotoma in area either above or below the fixation of point of horizontal line. Peripheral fibers are deep fibers and ring or double arcuate scotoma. It develops when two arcuate scotomas join together. Rohini central nasal step. It is created when two arcuate scotoma run in different arcs and meet to form a sharp right angle defect at horizontal meridian. Peripheral field defects. These appear at sometimes at early stage and sometimes only late in diseases. The peripheral nasal step of Rohini results from unequal contraction of peripheral eyes. After advanced glaucomatous field defects, the visual field loss gradually spreads centrally as well as peripherally, and eventually only a small island of central vision, tubular vision, and an accompanying temporal island are left. With the continued damage, these islands of vision also progressively diminished in size until the tiny central island is totally extinguished. The temporal island of vision is more resistant and is lost in the end, leaving the patient with no light perception. Diagnosis of glaucoma field defects on HFA single field printout. Field defects of glaucoma: bearing of blind spot, isopter contraction, B is superior paracentral scotoma, C is cedal scotoma, D is Jerum's or arcuate scotoma, E is double arcuate scotoma, and Rohini central nasal step. Let's see the criteria to grade glaucomatous field defects. The criteria to label early and moderate severe glaucomatous field defects from HFA central 30 to test single printout is defined in table 10.2. Assessing visual field progression in scotoma. Comparing the individual single field printouts obtained, overview printout in which up to 16 previously tested visual fields can be shown in a single printout. Progression analysis software is now available for statistical analysis of progression of visual field. Visual field index is a new measure which uses regression to others and trend-based analysis of speed of visual field defect. In it, a scale of 0 to 100, complete loss of field to normal full field is generated to grade the field loss. Ocular associations, PUAG measures with high myopia, Fuchs endothelial dystrophy, retinitis pigmentosa, retinal vein occlusion, and primary retinal detachment. Investigation, tonometry, applanation tonometry should be preferred over Shayard's tonometry. Central cornea thickness measurement is essential in workup for glaucoma since a thinner cornea underestimates and a thicker cornea overestimates the IOP on applanation tonometer. A low CCT is an independent risk factor for conversion of ocular hypertension to PUAG. It has been suggested that a correction factor should be applied to IOP readings in patients with CCT less than 545 microns and more than 600 microns. Diagonal variation test is especially useful in detection of early cases. Gonioscopy, it repeats wide open angle glaucoma. Slit lamp examination, perimetry, nerve fiber layer analysis introduced which can be detecting the glaucoma changes in retinal nerve fibers appearing of actual visual field changes or optic changes. Provocative tests in borderline cases. Water drinking test, it is based on theory that glaucoma eyes have a great response to water drinking. In it, after 8 hours of fast, baseline IOP is noted and the patient is asked to drink 1 liter of water, following which IOP is noted every 15 minutes. The maximum rise in IOP occurs in 15 to 30 minutes and returns to baseline after 60 minutes in both normal and glaucoma size. Rise of 8 mm Hg or more septemi diagnosis of PUAG. Diagnosis: primary open angle glaucoma diagnosed when IOP is greater than 21 mm Hg and glaucomatous optic disc with associated with definitive glaucomatous optic disc cupping and visual field changes, scotoma, etc. Ocular hypertension term is used when a patient has ocular IOP constantly more than 20 mm Hg. Then normal tension glaucoma diagnosed when typical glaucomatous disc cupping with or without visual field defects associated with intraocular pressure constantly below 21 mm Hg. Management: general consultation, grading, American Academy of Ophthalmology, grading, medical therapy, anti-glaucoma drugs are described in 4 pages. Let's see in future further reading. Basic principle medical therapy of PUAG. Glaucoma change is not likely to progress if we reduce the pressure. Although it is not possible to predict the safe level of IOP, lower target pressures till 12 to 14 mm are required in patients with severe damage. A single drug therapy, one topically instilled 20 mm should be chosen after consideration of patient's personal medical factors. In combination therapy, if one drug is not sufficient, 2 drugs can be given or more drugs could be given. Monitoring of therapy, regular monitoring is needed. Single drug therapy, anti-glaucoma drugs used for prostaglandin analogs. These decrease the IOP by increasing uveoscleral outflow of aqueous. Presently, a prostaglandin analog is being considered the drug of choice. For the treatment of PUAG. Further, this forms a very good adjunctive drug to beta blockers, dorzolamide, and even pilocarpine in additional therapies indicated. Available drugs are latanoprost, travoprost, bimatoprost, and uniproston, which should be used by BID daily. Topical beta blockers. These lower IOP reducing aqueous secretion due to their effect on beta 2 receptors in the ciliary process. Decrease aqueous secretion. preparation. In terms of evidence, there is a little difference between various methods. However, each offers a slight advantage over other, which may help in choosing the particular medication follow-up. Timolol is the most preferred drug. It's a non-selective beta blocker. 1 to 2 times should be instilled. Is most popular. However, it should not be used in patients with bronchial asthma and heart blocks. Betaxolol, being a selective beta blocker, is preferred in initial therapy in patients with asthma and other pulmonary problems. Levobunolol, its action lasts the longest, so is more reliable for once daily used. Corticosteroid, it raises triglycerides and lower high density lipoproteins the least. Therefore, it is the best choice in patients with COAG. And having associated hyperlipidemia or atherosclerotic cardiovascular diseases. Adrenergic drug, epinephrine hydrochloride, dipivefrin hydrochloride. These drugs lower the IOP by increasing aqueous outflow by stimulating alpha receptors in aqueous outflow system. Epinephrine compounds are no longer being used as first line or second line drug because of risk factor for failure of filtration of glaucoma surgery. However, dipivefrin may be combined with beta blocker in patients with where other drugs are contraindicated. Brimonidine 0.2% 2 times a day is selective alpha 2 adrenergic agonist and lowers IOP by decreasing aqueous production and also by increasing UVS scleral outflow. It is not considered drug of choice. POAG, dorzolamide or brinzolamide. These are topical carbonic anhydrase inhibitors which lower IOP by decreasing aqueous production by altering ion transfer along the ciliary process epithelium. These have replaced pilocarpine as the second line drug of and even as an adjunct drug. Pilocarpine 3 to 4 times a day. It is a very effective drug, had remained as the sheet anchor in the medical management of POAG for a long time. Presently, it is not preferred and it's not preferred as second choice also. It is because in fact in younger patients it causes problems due to accommodation and meiosis. Most but not old patients are used. Mechanism: pilocarpine contracts longitudinal muscle of ciliary body and open spaces in trabecular muscle, thereby mechanically increasing aqueous outflow. Combination topical therapy: if one drug is not used, if it is then a combination of one drug which decreases aqueous production and other drug which increase aqueous outflow. Similarly, beta blocker and prostaglandin can be used. Role of oral carbonic anhydrase inhibitor. Acetazolamide, methotrexate are recommended for long-term use because of their side effects. However, acetazolamide 250 mg TDS may be added to control IOP for short period. Hyperosmotic drug, mannitol 1 to 2 gram per kg body weight may be used initially when patient presents very high IOP. Neuroprotective drug, neuroprotection is an IOP independent method of treating the retinal ganglion cells that are damaging glaucoma. Some currently available neuroprotective agents have shown effects in vitro and in animal models. Our results in human clinical trials are either lacking or inconclusive. Laser trabeculoplasty, argon laser, the diode laser or selective laser trabeculoplasty. ALT and diode laser trabeculoplasty. It has an additive effect to medical therapy. In its hypertensive effect is usually by increasing outflow facility, possibly by producing collagen shrinkage on the inner aspect of trabecular muscle and opening the intertrabecular spaces. It has also been shown to lower IOP by 8 to 10 mm of HG in patients on medical therapy and 12 mm in patients who are not receiving medical treatment. Complications include transient acute rise of IOP, transient inflammation, other complications seen less commonly are hemorrhage, uveitis, peripheral anticyanic, selective laser trabeculoplasty based on principle selective photothermolysis target selectively pigment trabecular muscle or structures unlike ALT, DLT, SLT performed using Q switch frequency. Pressure lowering effect of SLT similar to ALT. Further, SLT can be used in patients treated with the ALT surgical treatment. Uncontrolled glaucoma despite maximum medical therapy, laser trabeculoplasty, non-comprehensive medical therapy, non-available ELT and SLT, failure of medical therapy, types of surgery, trabeculotomy and details of filtration operation describing page 254. Then we'll see about further in second part of the video.